Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged today to be with Dr. Omar Khalique. He is Director of Cardiovascular Imaging at St. Francis. Omar, always nice to see you.
You too, Chad.
Yeah, you have a nice niche, which is you are the eye of the interventionalist as well as planning for large surgeries for patients with heart disease. But one aspect of the heart that has been kind of not neglected, but we didn't pay attention to it lately, is right ventricle. So you are an expert in evaluating RV, when to intervene on the tricuspid valve, who is the candidate, and you are the one who's going to be triggering the intervention on these patients. So can you fill us on this topic?
Yeah, so I think, as we know, there are a slew of tricuspid devices now which we have available in investigations. And the tricuspid valve has always been the forgotten valve. We have these patients who have very, very severe TR, well beyond the normal limits of what we would consider severe. So new classifications have been developed, like torrential and massive, because that's the degree that we're seeing now. But actually the valve is being more and more recognized, but what's now being forgotten a bit is the right ventricle. So we have a much better handle on the left ventricle, on what it looks like, how to evaluate it, what does LV function mean. The right ventricle is more tricky and different. It's a more baggy ventricle, more compliant, perhaps more resilient, we don't know. From the imaging standpoint, the walls are very thin, so it's harder to evaluate.
Correct.
And the shape is less well understood compared to the left ventricle. It's a triangular shape and contracts in a different pattern.
Correct.
Now, our metrics for RV assessment so far have been very basic. So visual assessment is one, right, by echocardiography traditionally. Then the metrics we all know, like TAPSE, the way the base moves in one view. So that turns out to probably be very simplistic. The next step is going to cardiac MRI, where we can get a three-dimensional ejection fraction. But in the setting of TR, even that is fairly simplistic, because you can have one patient with EF of 50%, but half of that is going into the right atrium, and the other normal patient with an EF of 50% where all of the flow is going forward.
Yeah.
So that's a new concept known as effective RV ejection fraction.
Right. So that's great, Omar. So when do you think we should treat these patients? What are they say, you know what, this is the right time to do intervention of a tricuspid valve and this is the RV going to recover, or this is way too late, you know what, we cannot do anything for it?
Yeah, so that's the critical question, and I just don't think we know yet. I think first we have to really clarify what is the best way to assess right ventricular function, because as we mentioned, it's not as simple as right ventricular ejection fraction. So we have newer parameters now, RV free wall strain, which looks at the muscular contraction, and we're also starting to look at fibrosis in cardiac MRI. So how much interstitial fibrosis is there? That's been much easier on the left ventricular side because the walls are thick and easy to see, but newer sequences are being developed on the right side. Right. So what we really need is probably some type of scoring system. You know, what is the EF, what is the fibrosis, what is the size, and will this ventricle recover or not, based on the degree of TR reduction.
Right, and put it all together, come up with a score. Yeah,
that's right.
The one question, I'm not sure if this is relevant or not, patient who have severe TR from AICD lead or pacemaker lead, are they candidate for these kind of therapies?
So they are. So there are many different categories of therapies in the tricuspid space. So the ones most people know are the CLIP type therapies, TEER, edge-to-edge repair, and then total valve replacement with something like the TRISCEND trial. So the edge-to-edge repair are somewhat limited by the pacemaker leads, depending on location, and whether they're adhesive to the leaflets. If the lead is not thought to interfere with the site of deployment of the device, and it's not attached, then it's possible. For the tricuspid replacement, it's more liberal. So as long as the lead is not attached to a leaflet and it can freely move and there's enough slack, the replacement can be put in, and leads have been safely transitioned to kind of the edge of the tricuspid annulus without any adverse issues. There are also spacer and cable devices, some of which don't interfere at all with the leads. So I think we're going to have options moving forward once devices become clinically approved for this group of patients. But taking a step back, I think we need to reevaluate when we're putting in the leads and working with our EP colleagues to kind of guide this, whether it's on imaging or otherwise, and really assess what is our lead location,
Exactly.
and what is the safest spot for the lead to be in so that it's not going to cause these issues in the future.
Exactly. Yeah. Well, it sounds like it's an exciting time. Maybe hopefully we catch up a good time now to start to pick up on this right side of the heart. But again, we need experts like yourself to teach us how to evaluate and when is the right time to do the intervention to fix this valve. Omar, thanks for being with us. Really very insightful interview. Please watch this video and others on the CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Omar, thanks so much.
All right, thanks, Chad.